Like
Okay.
in the format of
Yes.
our thing.
How you would do it, yes.
Okay, so as a new patient, I would ask her height and weight to start with, and then when we get down to the chief complaint normally has notes on it that says what our injury was. So let's say she's in her for a right knee, okay? So I would say, hey, it says that you're here for your right knee. Is that correct? She'd tell me yes or no. I'd mark it on there. Like, not only does it say it, like, written right knee, but I would also check the box that says knee and then hit right.
Yes.
It's kind of like double confirmation.
Exactly.
Now, normally on a chief complaint, like if you go to an ER, if you go to another doctor's office, she would say something like, oh, my knee really hurts, or my knee's been popping, or whatever. You would write knee popping, or knee hurts, or knee pain, or whatever. We just do the check boxes.
Okay.
And then from top to bottom, the first couple of questions for me are already pretty much answered because she'll say that it's the right knee. So that first question's already answered because it asks you location. Now, the other part of that is whenever I say point with one finger exactly where your pain is, and let's say she points like right here, on your exam where it says location, it says left, right, but then it says medial, lateral, distal, proximal. It says all that stuff. So right there, you can put lateral.
But we're not doing exam. We're just doing intake. Do I switch?
This is intake.
Okay.
This is
okay, gotcha. Okay.
But normally what we do is I say, point with one finger exactly where your pain is, and I write it in the note sections because the girls don't look up that high to find it.
Okay.
And then I automatically click constant date of onset and moderate pain. Because usually when they first come in, they're either going to say my pain is 8 or 9, but they came in walking just fine and all that kind of stuff. Yeah. So I put moderate. It wouldn't be, if it was mild pain, they'd probably suck it up. Yeah. If it was severe pain, they'd go to the ER. Okay. Or they definitely wouldn't walked in here. So I always put moderate.
Sure. Okay.
Constant. Now I click constant, but when talking to her, if she's like,
comes and goes.
Well, I have this pain that's been coming and going, and this time it just hasn't gone away. That to me is still constant. But if she goes, I'll walk and sometimes it'll give out on me, or sometimes it'll pop and it'll hurt, that's intermittent, and I can change it to say constant.
So you'll just go back up and change it, make that mental change.
But I auto-click those because I can get those answers when I'm asking her about what's happening to her knee. Okay. Because a lot of the times they give you information not knowing they're giving you information or answering your questions when you ask them what's wrong with you. Okay.
And you can do that when you're walking up.
Yeah.
Yeah, that's why a lot of times when you see us coming up, we'll be like, so how's the knee feel?
Yeah, so you're gathering that already in here and stuff. Okay. See, I didn't know if that was patient confidentiality, though, because they're in here with other walking through the hall with other patients, if we should be even saying anything. I'm like, I'm so afraid of what we're taught is, you don't say nothing.
But I don't always say, oh, how's the knee? I'll be like, oh, how are you doing?
Yeah,
and they'll start themselves
their conversation.
Saying, oh, my knee's feeling okay.
Yeah, exactly.
It's not much better. Yeah. But so they're doing it themselves. I'm not breaching any confidentiality. Exactly. They start talking about it themselves.
So then from that point, then you go down and you do what?
Okay. After I'll ask them. The way that I ask them is I'll say, okay, so it's the right side. When did you get hurt is the first thing I'll ask them. And then that's when she'll tell me, oh, it was 2 weeks ago, or it was last week Wednesday, or whatever. And I'll go in on my little calendar on my computer. I'll actually click on it and I'll go and find what date she's talking about, because we need specific dates for the bill. Okay. And they'll be like, okay, now what happened to you? And then they'll start giving me their story. Okay. And I'll go in and I'll put, like, they'll say it's car accident or twisted my ankle or whatever. So I'll put that in there.
Okay. And that's under what area?
Context.
Okay.
Yeah. Timing is different than context.
Okay.
And just like duration or date of onset is different than timing and context.
Okay.
Because that's why they're different categories. So duration, we want the date. We want the date that they got hurt.
All right.
Okay. Context is how they got hurt. Timing is, was it acute? Did it happen like that? Yeah. Gradual, it's been building. Chronic, I've had pain for years and years and years. I just woke up and it hurt. Atraumatic. We don't know. There wasn't an injury. Okay. They just woke up one morning and it hurt.
Yeah.
That's atraumatic.
Atraumatic. Okay.
Yeah. So we don't know how they got hurt. They don't know how they got hurt. It just started hurting. It's atraumatic.
Okay.
And then the context is, was it twisting? Was it, bending, lifting? Was it a sport injury? Was it a work injury? Was it an MVA? Was it overuse? Was it a fall? All that kind of stuff.
Mm-hmm. Okay.
And that is where, if it was a fall, I'll double click on the fall. And then the notes is where I'll write what the story is.
Yeah.
Okay. And then after that, it asks you about aggravating and alleviating pains. So then after they tell me their story, I'll be like, oh, well, is there anything that makes your pain feel better? And 9 times out of 10, a patient at home sitting on the couch is not going to feel the pain.
Mm-hmm.
So I'll kind of, in my mind, I'll be clicking, weight bearing and
the common things for what's
limited
going on.
range of motion, or limited weight bearing and I don't remember what the other one was. Anyway, but I'll be clicking it and they'll tell me, So, and if they're kind of like, oh, nothing helps me, I'll be like, so if you're sitting at home on the couch doing absolutely nothing, it still hurts you as much as it does as if you're up and walking on it.
Mm-hmm.
And sometimes they'll be like, no, sitting at home doesn't
Resting,
hurt.
yeah, elevation, things like that.
And you can ask them questions too, like, well, have you taken any like Advil, ibuprofen? Has any of that helped you? And sometimes like, a little bit. That's an alleviating factor.
Mm-hmm. Oh,
And that's
okay.
over the counter NSAIDs
Yes.
or whatever.
Mm-hmm.
Sometimes they'll say, my pain meds help me. So you can put narcotics on
That's
there.
what I do. Okay.
Yeah. Aggravating, they'll tell you instantly. Big thing with knees is to ask them, does it hurt going up and down stairs? Does it hurt when you're sitting and then you get up to take off? Like, so those are the questions Dr. Matson always asks.
Okay.
And then associated symptoms. So I always say, aside from pain, have you noticed anything in your knee? Anything abnormal in your knee? And, if they don't really give you anything, that's when you can start saying, well, what about popping or clicking or buckling or grinding? And sometimes they go, oh, it pops. And I'll be like, was it popping before you got hurt? Or is it
bending,
popping?
like how we were discussing earlier, how when we bend, you hear your knee kind of click and pop.
Yeah, you can hear mine.
Yeah.
Like,
Yeah.
that would not be
Normal.
a symptom for me because that happens all the time.
Yeah.
Now, if they turn around and said, yeah, my knees pop, and I say, well, was that common before or is that new? Sometimes they'll say, well, it was common before, but now it hurts when it happens.
Gotcha.
That's a symptom then.
Mm-hmm.
The reason, like I said, the mechanical symptoms, so the difference, people are like buckling and instability are like the same thing. There's a difference. Buckling is like I'm walking and my knee just like
Gives
like
out.
that.
Okay.
Or it goes the other way, or it's walking and it comes backwards and it's like that. That's hyperextension, but it's also like buckling.
Okay.
Instability is you're walking and it feels like your knee could just go like that at
Okay.
any minute, And that's usually a really big sign of your ACL.
Mm-hmm.
Buckling and catching is a really big sign of loose bodies.
Mm-hmm.
So when we say catching, we're not saying buckling. What we're saying is, does your knee get stuck in a bent or locked position, and you have to shake it in order to get it to move again.
Okay.
Because loose bodies are getting stuck in your joint, and usually it'll stuck like this, and you have to be like, to get it loose again.
Yeah. Okay.
That's catching or locking.
Mm-hmm.
Swelling, those are usually pretty common. Fractures, bruising, and swelling are usually pretty common. And then after I ask them if there's any other symptoms, then I'll be like, okay, have you ever had surgery on this knee? They'll tell me yes or no, or I'll know because they've had surgery with Dr. Matson. And then I'll ask them, have you had any MRIs, x-rays, anything recent? Some people will be like, oh yeah, I've had an x-ray. And I'll be like recently, like in the past 2 weeks? And sometimes they'll say no. If they say no, I'll put no recent studies.
Okay.
Even if they were like, oh yeah, like a year ago I had an MRI.
You still put no
I'll still
recent
put
studies.
No recent studies.
Okay,
because
gotcha.
A year ago MRI is no good to us now.
Gotcha.
Especially if it's before the day they got
And an X-ray, unless Matson's taken it over 2 weeks,
it's like ideally you want to get it within a week.
Okay.
Because
Things change on that
take
bone. Yeah.
6 to 8 weeks to heal,
Mm-hmm.
and anything over like 2 weeks is really not going to be too helpful.
And then so I don't want to interrupt you. So then what goes on from after that?
After x-rays?
After X-ray. Mm-hmm.
Okay, so after you ask them about if they're doing any x-rays, you ask them, have you had any injections, physical therapy, have you had any braces, have you had any medications, anything that
Specifically for the area they're here up to be seen about.
Yes.
Not any other part of their body. Okay.
The way that I would phrase it is, have you seen a doctor for this already?
Mm-hmm.
And if they say yes, I'd be, did that doctor do anything for you?
Okay, gotcha.
Did they give you any medications? Did they start you in physical therapy? Did they give you any injections?
So I was telling Marcia, I have a lot of times where they'll go into the story and it has nothing to do with the part they're here for. And I'm like, now what about the part what about the knee? Forget the,
Yeah,
It's like,
a lot
there
of
you
our
go.
patients, you have to redirect them because they are just not telling you
Golly,
the
they're
story.
just demanding almost about,
Yeah.
like, you're going to listen whether you want to or not.
Mhm.
I'm going to tell you about when I was 18 and had a car wreck.
And then after I get all those questions, that's when, actually usually at the very end is when I'm like, okay, now if you had to point with one finger, tell me where most of your pain is.
And
I'll
where
write
do
that
your final notes go into? Under what area?
The bottom.
At the very
Where it
bottom,
says notes.
where it says notes. That's where you finally put your words.
Like the thing that's like that big, not the like
Yeah.
single line
Yeah.
section.
You will put in your medical notes what you think.
Mhm.
Okay.
And sometimes the patient will be like, yeah, I went and saw this doctor and I didn't really like him, so I'm here now.
Exactly. That's what I had.
But there's things too, like, let's say that, they've had an injection or they've had physical therapy. They said, yeah, I had an injection, but it didn't really do anything for me. I would put had an injection and didn't help, or help for a little while, or whatever, and then I make a note in there that it was by another physician, because Dr. Matheson's going to ask you, have they had anything done for it? And you can say, well, yeah, but not by you.
Yeah. Gotcha.
And then still tell him what they had done, because then he can eliminate what he's going to do.
Mm-hmm.
Okay, so they had an injection, it didn't help them, so why would I do it again?
Okay.
Or they had an injection and it was within the last 3 months, well, I'm not going to give them another injection because it wears on your cartilage to have too many injections.
So who do we do 3 injections on? What?
Orthovisc.
Orthovisc.
Those are
And
gel
and how far
injections.
apart are they?
A week.
A week apart. And they only have 3, then they have to wait 6 months?
They don't get them again.
Then they don't
They
get them again.
usually don't get them
They
again.
usually don't get them again.
Usually. He usually won't repeat it. If they don't help the first time, usually what he'll lead you towards is a knee replacement.
So he might.
So is the
He
Orthovisc
could
only for the knee, or can it be
Yes,
in the
studies
shoulder?
have not been done on any other body.
Okay, so what is the other injections we give?
Cortisone.
Which goes anywhere
Any
he
joints,
please.
yeah.
Okay, and then the
It's a
other one,
steroid
there's
injection.
the one that's the lubricant.
That's the Orthovisc.
That is the Orthovisc. Okay, and then which ones do we not take the patient out of if they've had like their sling or their?
Oh, you don't take a patient out of their, well, you don't take any patient really out of their sling if they come in from surgery
Okay.
and they've got like a sling and stuff like that. You usually don't take them in, but you definitely don't take them out if it's from a rotator cuff repair or a labral repair.
Okay.
Slayo, please talk to her.
Okay.
She's here?